Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown. This is the story of steroids and testosterone, part 1. Dr. Travis Brown, I know you've never really described my physical attributes to our listeners, have you?
I don't think I have, no. We tend not to describe people that in those terms these ways, but if I can probably describe, it's sort of Arnold Schwarzenegger-esque kind of, muscular physique, athletic, probably.
Okay.
Yeah, it's...
You can come back. But that's me riffing stereotypically when I hear these topics being raised, but we're going deep into it for our educated listeners.
We're wanting to separate this in almost two different areas. When I came across I've always loved sort of sports, athletics, loved that side of life. And anabolic steroids is one part of this, but also the medical side. So looking at hypogonadism. So the people who don't have enough, medically don't have enough. And that can be children, it can be adults. And so we've separated this as testosterone, steroids into sort of two areas. The first one being medical hypogonadism. We split that into primary and secondary, but we'll discuss that a bit later. And then a second one looking at kind of recreational use of anabolic steroids and the gym culture behind that.
Don't look at me so intently when you say that.
And this is one of those areas that sort of delves into the area of people taking it either through the internet or getting sources of it. But we're also wanting to care for both sets of patients. We're wanting to care, medically, who do we need to pick up that potentially have problems that we need to supplement with the hypogonadism. And then you've got the people who take steroids, how do we look after them whilst they're taking steroids? How do we look after them after they've taken steroids? What risk factors do we need to know about? And so this is an area that's important because, again, I've got young adolescent kids and I'm sort of knowing that, look, they're both athletic, both sporty. This will be something they come across regardless of whether they want to do anything like this, but it's about being knowledgeable about that. And that's, knowledge always helps. And when we're discussing with people or kids, knowing what they're going through or what they're wanting to do, because sometimes there will be a disconnect. This is looking at medical hypogonadism. So, if you break down the word, hypo, low, gonads. So, and this is where we start to understand historically the role of testes has actually been known since antiquity. And the reason why it's been known is because, oddly enough, through eunuchs and castration. So in the ancient times when sort of people would take over another people and make people slaves, well, of course, what they did, they'd castrate the male population and they would become slaves. But and they knew that if they castrated, young prepubescent boys, they would never go through puberty. They would actually remain prepubescent throughout life. If they castrated adults, they would have loss of libido. They would have erectile dysfunction if only the testes were taken. They would have muscle loss. And so they knew that there was something to do with the testes and the genital region to do with development, sexual characteristics. The scientific role, though, it wasn't actually until the 19th century that the physiological element was started to be tested. And this was Dr. Arnold Berthold. He was a German doctor. He was a physiologist as well as a zoologist. Now, he's essentially like a pioneer of modern endocrinology. And he did an experiment on roosters. And he got 6 roosters. He put them into 3 different groups. In the first group, he castrated both testes off the rooster for their development. The second group removed 1 testis from those roosters. And a third group removed the testes but implanted 1 into the abdomen of the other. And so these 3, the belief at the time was that the testis signaled what the secondary characteristics was through nerve conduction. So if you severed the nerves, then there would be no way to communicate how to develop further. It wouldn't be able to send messages, and you wouldn't get any secondary characteristics. But
so the testis cut off and put in the stomach has severed that connection.
That's right. And so it shouldn't work at all. Yep. So it should be just like the castrated. And what he found was the first group, so the completely castrated, they became very docile, not aggressive, not interested in hens, didn't crow, and effectively just...
Didn't lay eggs?
Beautiful. So we might get to that a little bit later about birds and the bees for you. But when we're looking at it, no, didn't display any of the normal rooster characteristics. And so the second group, though, which only had one testis removed, didn't change its behavior at all. Actually, it became full, like indistinguishable from a rooster. It was aggressive. It would fight with other roosters. It would chase hens. And so there was no actual discernible difference. And then the third group that had the transplanted testis into the abdomen of the other one actually was just like the second group. So it was still aggressive. It would still chase hens. It would still crow. And so it was indistinguishable, even though they had moved the testis and transplanted it into the other one. And so when they actually examined the rooster, they found out that the abdomen, the testis in the abdomen had actually revascularized.
Oh, wow.
And so from the colon region, it had its own blood supply. And then he realized that it was the blood supply that was actually the thing sending the messages and not the nerves. And so this was a fundamental changing. Something was coming from the testis that was sending the signal to the body about
the blood.
Via the blood and not the nerves. And so around this time, a similar time, we got a Dr. Brown Sequard. Now, he was a 72-year-old physician. This was in the 1890s, around 1889. Now, he was 72-year-old, and what he sort of termed was, well, he's getting older. He's losing his male virility. What he called it was spermatic anemia. Wow. And so he looked at men at the age of 20 and 35, and he interpreted sort of, if men abstained from sex during that time, they became greater physical specimens, and their mental acuity was increased, and so this must have been something to do with the testis. So they were greater than those who did have sex. And so he, in his 70s, thought, well, over the last 10 to 12 years, I've lost my strength. Sometimes I have to go to work and I have to sit down. I feel weak at times. And so, after 3 or 4 hours during work, he feels tired and he was having poor sleep. And so he wanted to do an experiment, and he wanted to do an experiment on himself. Yes. And so he ended up getting liquid from testes in animals. And so they would actually take the liquid from the testis, and he would crush it up, mix it with water, and he injected it into his own skin. He did this over about 5 times over 2 weeks. And after 2 or 3 injections, he felt his strength was increasing. His weakness was reducing. He was able to lift heavier weights because of it. He didn't feel the need to sit down. And he even decided to measure how far he could wee as a sign of manliness.
Should you be putting a spotlight on people like this?
Well, he was a physician at the time, and this was his knowledge. And so what he found was that he could wee even further after the injections. And his bowel habits improved. And then when he ceased having the injections, everything returned to baseline. And so this was sort of an experiment he did. And then another doctor took note of this and said, well, let's start experimenting on patients. And so they got 3 patients, the age of 51, 56, and 68, and they all had the same results. So they got this injection, put it into their skin, and they found that they were stronger, more virile, and could wee further.
A medical pissing contest.
Literal. And look, what they found was that the secondary characteristics and what they thought was going on was that somehow there was something in the testis that was making them feel better, stronger. And so again, they still didn't know about testosterone at that point in time.
Sorry, Travis, that's also cross-species, isn't it?
From animal testes?
Yes.
Well, the hormone, yeah. So, but the important thing is they later revisited that several years back, decades, and I'm sure after Dr. Brown-Sequard had passed on. And they found out that the amount of testosterone that they were injecting themselves wasn't clinically significant. Oh. And so it actually meant that all this...
Placebo?
Yes, exactly. Oh. And so, however, the important aspect was there, yes, that they were looking at what they were wanting to do is there was something to do with the testis that was important for them to find out. We were able to isolate testosterone in the mid-20th century. But again, the important part is it's really small, the amounts we're talking about that are going through into the body and being used. And this is important for detection. This is important for monitoring. This is important for knowing what levels are normal and not normal. And so this is the part where we start to understand, and this is where we start to understand primary and secondary hypogonadism, meaning that the testes are really important for developing this hormone, for sexual characteristics and development, puberty in men. But if you have a primary function with the disability of the testis, then it's not going to produce enough testosterone to get that. That's what we call primary. Yep. And so your body will try and stimulate that, but the testes can't produce it. That's primary hypogonadism. We have a few causes for that. Klinefelter syndrome. If someone's had radiation or even injury in the area, then it may fail to produce enough testosterone for the person. That's primary hypogonadism. If you get secondary, it means that the body's not stimulating the testis enough. So the testis is fine and able to produce, but it's not getting enough signal to actually produce that. This can be a pituitary problem. This can be for other characteristics. And so we're needing to understand what's going on. We are needing to sort of put it into those categories because it's important for treatment, what actually needs to be replaced or managed. And so this is what we're looking at today. We're looking at the medical hypogonadism and understanding for patients about replacement, and how do we investigate it, and so how do we manage it from there.
Professor Duncan Topliss is Senior Endocrinologist of the Department of Endocrinology and Diabetes at the Alfred Hospital, Melbourne, and Professor of Medicine in the Department of Medicine, Monash University, Melbourne, Australia. He is a past president and life member of the Endocrine Society of Australia. He's been involved with the development and implementation of clinical practice guidelines for diabetes and other endocrine diseases at the local level over many years. He served on the editorial board of Clinical Endocrinology and is a frequent reviewer for Clinical Endocrinology, the Journal of Clinical Endocrinology and Metabolism, Thyroid and other endocrine journals. And Duncan's our guest here on This Medical Life podcast. Duncan, welcome.
Thank you very much. Good morning.
To begin, I'd love to know just how common is hypogonadism in men?
Generally, something about 1 in 200 men may have hypogonadism. It's not that rare, no.
Saying that it's that common, to be honest, is it possible for adult men to have hypogonadism and be unaware of it?
Before I answer that directly, I said we don't advocate general population screening, and low testosterone levels don't constitute a diagnosis. And there is an age-related decline in testosterone. It's about 1% per year, I guess, over the age of 40 or so. And that's not hypogonadism. And whether and the risk versus benefit of treating that, I mean, it's not advocated, is just not known and can't be recommended. But so I don't think that someone who's completely well will have hypogonadism, but a man could be unaware that the symptoms he has are in fact due to hypogonadism.
So when should doctors then consider, could this patient have hypogonadism?
Well, I think case finding, if you like, should be considered when you've got a symptomatic individual or a person in a high-risk condition. So what does symptomatic mean? Or symptomatic could be sexual symptoms, so it could be reduced libido, erectile dysfunction, reduced morning erections, infertility, or it could be more, perhaps less specific physical symptoms, reduced body mass, strength, easy fatigability, reduced stamina, reduced growth, or loss of body hair. Some of these are rather non-specific and could have a number of, obviously, other causes that aren't related to hypogonadism. But that's the sort of picture. But then, of course, if you've got somebody who's had a disease, they've had chemotherapy, radiotherapy, something of that nature, then they may well be, you regard them as perhaps a high-risk individual and might look at it in those people.
Duncan, you mentioned erectile dysfunction as possibly one of the symptoms that we're talking about here. If a patient is getting their hands on those little blue pills they're using to counteract those effects, does that mean they could get by and their GP doesn't really know about it? They go through unscathed, as it were?
Well, that sort of treatment, the phosphodiesterase type 5 inhibitor therapy, is effective for many men with a degree of erectile dysfunction. The vast majority of men with erectile dysfunction do not have hypogonadism. So I guess, and it could be have some efficacy in men who are hypogonadal. So, we would recommend that it would be reasonable to look for hypogonadism, but you wouldn't expect to necessarily to find it.
Is the distinction between primary and secondary hypogonadism useful clinically?
Well, I think it is, because it's fundamental to the proper diagnosis and treatment. I mean, if you've got someone with secondary hypogonadism, by which we mean it's a pituitary or hypothalamic disorder, then they may have other components of that which are vital to identify. I mean, if it's due to a pituitary tumour, the tumour could be something that could press on the optic apparatus, the optic chiasm, lead to problems with vision, etc. Or there could be other endocrine deficiency of thyroid or adrenal function, which could be causing major and sometimes even life-threatening problems. So I think it's essential to make that distinction. And of course, if it's primary, then you'd be thinking about why is the testis injured or not functioning properly, because that may be something that's happened, a trauma, or orchitis, etc. It may not be reversible. But of course, it's important, I think, to make the diagnosis. And also, if fertility is an issue, then it becomes important, because the nature of the treatment will be different if someone's got primary testicular disease versus secondary hypogonadism. I mean, in secondary hypogonadism, we will be looking for fertility treatments, which may also improve testosterone, would improve testosterone, but with the aim, of course, to improve fertility. Very different if you've got primary testicular disease, where that form of treatment would likely be quite ineffective.
Is there many people that are detected at the fertility level as having hypogonadism? Sort of like, is that almost like a presenting complaint?
Certainly it can be. I don't practice in the infertility area, but I think that it would be routine to look at the male factor as to what's going on, and that would include assessment of gonadal function, not only sperm production, semen analysis, but of course whether the testes are functioning and the pituitary gonadal axis is functioning normally.
Is it enough to test testosterone, LH and FSH to identify these patients?
Yeah. Well, I think it's important to make that in the context of, like all clinical medicine, you're making an assessment of the clinical situation. So fundamentally, of course, we must take a good history and examination to identify what the clinical situation is. We know that, what's the state of the testes, etc. But if assuming that's all been done, then measurement, of course, of total testosterone and with the relevant gonadotropin, which is most important, is LH, because that's where testosterone and LH are more closely allied. But I would generally look at FSH as well, and also prolactin, because that's a clue to hyperprolactinemia impairing testicular function. And I generally would include a sex hormone binding globulin assay, because that helps us interpret the total testosterone. Some men will have a low normal sex hormone binding globulin, which isn't really a disease state, but it would help in interpretation of the testosterone. I mean, a lowish testosterone with a low sex hormone binding globulin would mean that the actual effective or free testosterone is pretty close to normal. So whereas a very high sex hormone binding globulin might mislead you. So although total testosterone by a valid assay is the key thing, those other tests you mentioned, plus perhaps including prolactin and sex hormone binding globulin is what I would recommend.
So I was going to ask, when is a replacement appropriate? But I'm assuming we've diagnosed. How do you actually diagnose hypogonadism?
Well, I think you've got the clinical scenario, so you're suspicious, and then you find that the male has a very low testosterone. So the testosterone level is a key factor in the biochemical diagnosis, and there are a range of levels. We've got criteria that have been evolved for this. I mean, in general, testosterone in hypogonadism will be lower than, say, around 6 nanomole per litre. I mean, there's a sort of grey zone of 6 to 10, maybe even a little bit higher. And if it's primary hypogonadism, in those men, we'd expect to see a high LH. So that would be helpful. And also it's helpful in deciding about eligibility for testosterone therapy.
One of the things that I'm finding a lot with patients there is the ability to get access to hormones over the internet or even across the counter or anything like that probably won't show up in assays. How would we know if someone's taking extra hormones that might be interfering with our assessment of hypogonadism?
Yes, you're quite right. I mean, that's a real issue, and we don't know often what's in any of these. And they can be a major issue. I mean, there's lots of so-called anabolic steroids out there, which may well interfere with the assays or suppress LH, reduce fertility, of course, if you're suppressing testicular function, and they may well have other adverse actions as well. So it can be very difficult. The pattern would be that you might actually have a low testosterone because these agents suppress pituitary function, so the natural testosterone level is reduced. And if these agents don't show up in the assays, many of them won't, you would need to have specific assays to pick those things up. I mean, clearly people who are doing this, you would hope that they might tell you, but it's in the nature of things that they might not divulge this. Yeah. And of course, as I said, we don't know what's in a lot of these things. And the point I wanted to make about anabolic steroid, anabolic is a word used, favoured in these circles to say it's really not. It's having a different effect other than testosterone. But these are all working through the androgen receptor. They're all anabolic steroids are all testosterone analogues of various forms. So calling them anabolic steroids is a sort of a weasel word. Huh? They're testosterone. They're acting through the way in which testosterone works, maybe very excessively, etc. So I think a lot of these people might not realise that if fertility is an issue for them, these agents may be very adverse on fertility.
If someone does have hypogonadism, what treatments then, from a medical perspective, what treatments are available for these patients?
First thing, it's important to identify in that particular person what is the issue, because if fertility is an issue, then just putting someone on testosterone can be an adverse effect. I mean, testosterone therapy may be quite important for that person's physical status, etc., but testosterone can suppress sperm production. So if fertility is the issue, it's important to identify what's going on. And that's where it's also important to identify whether it's primary or secondary hypogonadism, because if it's secondary and the person wants fertility, then one is looking at pituitary gonadotrophin therapy to induce fertility and to improve testosterone levels. So it can do both, but that's important to do that rather than just give people testosterone therapy. Now, of course, there are many men in which that's not an issue, and they've got genuine hypogonadism. Testosterone therapy would be the appropriate treatment in that group of men. And then it's a question of which form of testosterone we choose. In days of yore, there were oral forms developed which we now know are hepatotoxic and quite dangerous, so we don't have really a a high-potency oral form of testosterone available. And this is, of course, an issue of what people might be buying off the internet. Methyl testosterone hasn't been used, I think, in Australia for probably 50 years. It was taken off the market, I think probably late 60s, early 70s, because of its toxicity. And we do have an agent, testosterone undecanoate, as a capsule, although its availability is quite difficult to get. That's safe because it's absorbed through the lymphatics, and it doesn't go through the liver. But you need to take a lot of it, and many capsules a day. And it's quite a gentle treatment, but it's not really very practical for an adult male to take lots of those capsules. So that's why I think the forms either as a gel, which is absorbed through the skin. There is a cream as well, which has to be applied to the scrotum, but the gels can go through ordinary skin. And that is a daily treatment. And then we've got the injectable forms, and we've moved mostly across, I think, to using the long-acting injectable form of testosterone undecanoate, with the trade name is Reandron 1000, and that's an injection, intramuscular injection, which is given roughly about every 3 months. Some people, we check the levels pre-dose and may want to adjust it up or down a bit so that we can so some people need it every 2 months, some people may be able to have it every 4 months, and that's it's 4 mils of oily preparation. So it's got something. Only place you can give it is into the buttock, and people get used to it. They don't mind it, but it's got to be given carefully into the buttock. It's not something you can give in about 5 seconds. You've got to have the person relaxing on their stomach and inject it slowly into the buttock, and but it's only every few months. So that can be that's pretty much become a standard treatment for many men with hypogonadism. But others quite like the gel or the cream, so that can be quite useful. You can measure the level. They will have a pretty steady state level if they are using it regularly every day, whereas with the Reandron, they'll get a fairly high level initially. It will gradually fall away. But for most men, that isn't really a problem in the way they feel, but they might notice it running out, as it were, and that's where we need to check the pre-dose level and adjust the dose. And of course, the treatment is also based on how they respond to the treatment clinically, how they feel it's going. And we have safety issues there as well. Which are manageable. If too much, you can get polycythemia, so we always check the hemoglobin, make sure we're not driving that up too high. You can get hypertriglyceridemia. So there's a couple of things to monitor apart from testosterone level as well.
I just note with that injection into the buttock, you would want to make sure you have a doctor with good bedside manner, surely.
Indeed.
Yes.
Indeed. I think people have to understand what they're getting themselves in for. And one of the interesting little side effects, which unfortunately is not very common, it's a transient one, but if you inject it and it gets a little bit into the venous system, you get a little embolus of this fatty goop going around, goes into the lung, and I've only ever had this happen, I think, once. They get a little fit of coughing, and then it all settles down. So it's not dangerous, but it's something that can be quite alarming if people haven't heard about it. But it's really quite uncommon, and it won't necessarily ever recur. But it's just a little dramatic event that can occur at the time of injection, which can be a bit off-putting if you've never heard about it.
With that, when you said you monitor the patients with regards to it, now we noted that some of the exogenous testosterone isn't detectable by the assays that we use. So are these ones that are the medication, are they detectable by the assay, or are they forcing testosterone to be produced?
Oh, no. When you're injecting testosterone, you're injecting the steroid, which is the same as human testosterone produced by the testes, and we have assays to measure that. Now, I think you're going to be talking to Professor Sikaris about this later, but who's a biochemist, but testosterone assay is a bit tricky. I mean, the best assays now are the mass spec assays rather than radioimmunoassays, but radioimmunoassays are still widely used, and they do read reasonably well. Other agents might not read in the assay, and that's where systems which can validate across a range of different steroids, can pick up whether people are using other agents. And of course, this is standard in sport to detect the use of these agents, but they're completely different form of assay to what's being used routinely in clinical medicine. But no, we can measure testosterone. It's not perfect, not always, but it's increasingly we're moving across to using these mass spec assays for measurement of steroids, including testosterone, in routine clinical medicine. And they are much more reliable.
You'll see patients who have hypogonadism. What's some of the common questions they ask?
Well, I think the patient may be confused about the difference between fertility and hypogonadism, and also the issue that people have that's out there on the internet about so-called male menopause, which is not a real phenomenon. So they may have been told, I need testosterone. So it's necessary to discuss the issues, what's their clinical problem, what actually is their diagnosis, and they may be, sometimes you have people who are unhappy, they've come along, you're the doctor that prescribes testosterone for me, and you may not feel that's the appropriate indication. So it's necessary to obviously deal with what people what their concerns are and deal with them properly. But of course, giving people testosterone whose problem is erectile dysfunction with normal gonadal function is not going to be helpful. And we have lots of men who are, in their 40s, 50s, with some degree of 60s, with some degree of erectile dysfunction. It's not a quick fix to give them testosterone at all. And one should be looking at a whole range of other factors. When people are overweight, they've got diabetes, hypertension, etc., too much alcohol, all these sorts of things, which in fact general practitioners are particularly good at assessing these and evaluating, advising people about this, and this can be much more important for their general health and well-being, and in fact down the line for improvement of sexual function. So there's a whole issue of sexual function which is not related to hypogonadism, and so it's important to sort that out and to educate the person, see if you can get them to understand that this is the way to approach it, not just a simple injection every so often. But of course, a lot of people don't like that advice and go off and buy stuff off the internet, etc.
I have one line of curiosity here. In This Medical Life, we cover all sorts of diseases and conditions. Some people are very comfortable to raise with their doctor, others less so.
Yes.
Do you have an intuition about who starts this conversation the most about hypogonadism? Is it something a patient comes to raise with a GP, or is it something a GP might note and raise as a possibility?
Well, I'm not in general practice, and of course I've got a referred practice, so people are coming along that's sort of been already identified, or there are high-risk situations that have been referred by another specialist like an oncologist, etc. I don't think most men come along saying, I think I might have hypogonadism. They come along with specific symptoms. They may be, and I would say erectile dysfunction is one of the commonest presentations of the problem. And of course, it's absolutely important to identify where that is part of hypogonadism, because the treatment of hypogonadism can be very rewarding in this circumstance. So I think that there's a range of symptoms that people can present with.
Just finally, do you have any thoughts for doctors or patients that you'd like to leave with them in regard to hypogonadism?
I don't think it's that rare, and I think it's important to identify, and it's important to make a proper diagnosis, and the treatment, obviously depending on what the patient wants. If they want fertility, if they want sexual function improvement, if they want general improvement in quality of life, and the symptoms and signs are related to this. So it's important to identify it, I think, and to have what we've been discussing today, which is a sort of fundamental understanding and a sequence of evaluation, clinical, and then testing and then selection of treatment.
Professor Duncan Topliss, thank you very much for joining us on This Medical Life.
It's a pleasure. Thank you very much.
Professor Ken Sikaris is a chemical pathologist and director of chemical pathology at Dorevitch Pathology. Professor Sikaris is a NATA-accredited laboratory assessor, founding fellow of the RCPA Faculty of Science, and a principal examiner in pathology informatics. He's a fellow of the Department of Pathology at the University of Melbourne. Professor Ken Sikaris is a regular guest here on This Medical Life podcast. Ken, welcome back.
Hi, Steve. Great to be back. I enjoy these sessions.
Oh, we look forward to it. Ken, when is testing testosterone actually appropriate?
Well, there are places that are really necessary, like in children with delayed puberty, or women with hirsutism and androgenization, men with infertility, just as a test for gonadal function. The more debatable part is what level of tiredness and weakness and lethargy justifies testosterone measurement, and virtually a whole pituitary axis study. Yeah, but I think there's some obvious things and then more vague area.
Now, you did mention just pituitary, because often this goes on to, like, even if you get sort of an abnormal thyroid test, some of the automatic responses sometimes is test all the pituitary hormones. Do you subscribe to that view?
Not really, because usually there's some sort of clinical clue to which hormone's missing, whether it's, fertility or gynecomastia or thyroid dysfunction and so on. And so usually if that points to a central problem, then you're wondering whether there's more than that particular hormone axis to be impacted. You want to see whether there's a pituitary disease, how much of all the hormones axis are affected. So, yeah, because hypopituitarism, particularly in the situation of chronic fatigue, it's really just a fishing expedition when you've got no clear clues.
So is testosterone that we're looking at and discussing in these episodes, is testosterone a good assay?
Now, this is something that deserves a little bit of clarification. Was in the past, it was a lousy assay. In chemistry, when we measure things in millimoles, that's fairly easy. Like sodium and so on. When we measure things in micromoles, which is 1,000 times less, like some hormone there, like dihydroxyepia, it's an adrenal hormone, DHEAS. But then with testosterone, we're getting down to nanomoles, 1,000 times lower again, so 1,000,000 times lower than sodium, let's say. And, if we can be critical of testosterone assays being very difficult to measure such low concentrations, well, once we get to estradiol, picomoles, like it's 1,000-fold less again. And so it was very hard traditionally to measure nanomole per litre quantities with assays, and it's still very hard to measure picomole per litre quantities, which we might get to. The other aspect of it was that when you're down at that level, you need such high avidity antibodies, if you like. The risk of cross-reactivity with other low-level things or other high-level things is a problem. And the thing that was really interesting, because DHEA, which is an androgen from the adrenal, is present in 1,000-fold higher concentrations than testosterone. And so a lot of the older assays for testosterone, they had a 0.1% cross-reactivity with DHEA, but DHEA was present at 1,000-fold higher concentration. So those assays were actually measured DHEA as much as they were measuring testosterone. Now, about 10 years ago, the monoclonal antibodies became much more specific, and so there was very little cross-reactivity with DHEA. And that had two effects. One was that patients that had high levels of DHEA, you wouldn't get that confusion about whether there was testosterone there. But the other thing was, now that there's no cross-reactivity, the levels are even lower, like it's purely testosterone. And so it's very hard to get down to those very low levels still. Now, for men, there's not a problem, because men have got, their concentrations are 30 or 40 nanomole per litre. We can manage that. For women and children, the concentrations might be 1 or 2 nanomoles per litre. And that is very difficult for most immunoassays. It's been improved with the absence of DHEA cross-reactivity, but it's still a problem. And so a lot of endocrinologists do prefer going to, the really highly specific and sensitive assay of spectrometry to measure those low levels. But, it depends what you're looking for. If you're looking for testosterone deficiency in a child or a woman, you're going to need very sensitive assays. Whereas if you're looking for androgen excess in a woman, where the levels mightn't be 1 or 2 millimole per litre, but 3 or 4, now you can't, the modern assays can do that. So the short answer is for men, no problem whatsoever. For women and children, if you're looking for deficiencies, you probably need mass spectrometry.
Aren't you both glad you're working in this era in medicine? Like in the 1800s, there would be no way on earth.
Yeah, no, it is miraculous, Steve, what we take for granted. And not only that, I should say, with testosterone, because when I'm talking about cross-reactivity, the difference between the steroid molecule testosterone and the steroid molecule of, estrogen or progesterone may be 1 atom. So, and that still blows my mind that an antibody, which is a giant molecule, can pick up such a tiny difference in a much smaller molecule. It's
okay. I'm going to have a Bex and a lie down after that.
Now, looking at primary and secondary hypogonadism, is there a difference? Is there a sort of, does it make any difference what you're testing when you're actually, does it make a difference to us when we know, is there a difference between primary and secondary hypogonadism with these tests?
Well, it's very important because you want to know whether the pathology is in the primary, in the testes, or secondary, indirectly in the testes, let's say, and in the pituitary hypothalamus. So we want pathology, so we definitely need to know whether it's primary or secondary. The testosterone doesn't tell you that. The testosterone just tells you the end organ effect. Because of the feedback mechanism, what we need to be able to detect reverse secondary is the pituitary gonadotropin. So it's specifically LH. LH is what controls the Leydig cells, which control testosterone production. FSH sort of interest because FSH controls the Sertoli cell, the follicular cells, of the equivalent of men, and that controls spermatogenesis. But it is logical to say, well, if a patient's got testicular insufficiency due to a secondary cause, a pituitary cause, then is it just testosterone or is it also spermatogenesis? So we are interested in FSH, but the prime relationship is between LH and testosterone. So if LH is high and testosterone's low, well, the testes are being stimulated, but there's no testosterone production, so that's primary. Whereas if the LH is low and the testosterone's low, well, the problem is the central drive. So it is very important to be able to, and really, I mean, you can run the testosterone straight up, find that it's low, but without the LH, you've still got no idea what's happening. So you could run it as a reflex or a secondary test, but really, the more efficient way and the more clinically effective way is to, whenever you order to query testosterone deficiency, to order LH.
So all order them all together. Testosterone, LH, and FSH would be recommended. Well,
for fertility, definitely include FSH. You're just looking at the testosterone, the anabolic or the lack of anabolic. Then just LH and testosterone.
Now, if someone's taking exogenous testosterone, will that be measurable in this assay?
No. Like I was saying before, the antibodies are so specific with a 1 atom difference. They're trying to distinguish progesterone and estrogen from testosterone. The anabolics are almost completely different molecules. They do have a similar structure. There are many, many atoms difference between an anabolic testosterone and synthetic testosterone and natural. So almost none of them cross-react with our modern assays. So all you'll see is a low testosterone because the anabolics suppress the pituitary axis. LH is low, testosterone is low, so it looks like a central problem, which it is. It's because the anabolic is suppressing the axis.
Are there any other tests that are appropriate or useful for patients when they're being investigated for hypogonadism?
Well, look, there is one really important test, and I should have probably led off with this. Testosterone is a fat-soluble hormone. It cannot exist on its own in an aqueous environment of the blood. It's carried by a protein. All steroid hormones are carried by a protein. Cortisol binding globulin binds cortisol. Thyroid binding globulin, binds thyroid. Thyroid hormone is a steroid-like hormone. So sex hormone binding globulin binds testosterone. So when we measure total testosterone, it's not just an issue of how much testosterone the body's producing, but how much binding protein the body produces, because it's sort of like the trucks. Testosterone is present either inside the trucks or free outside the trucks, so it's ready to go into the cell, like it's left the truck and going in. There's bound testosterone to SHBG, free testosterone, which is what cells have availability to. That's the free hormone hypothesis. So, but the concentration of trucks is the confounder, huge confounder when we're measuring total testosterone. And so now we can measure free testosterone, we can try to. It's very difficult. The concentrations are in that picomolar range. Very difficult to measure. There need to be direct assays, single-step assays for free testosterone, and most endocrinologists consider them rubbish. There was a relationship between the true free testosterone, but considering all the cross-reactivity and issues, they weren't very good. Nobody does, well, I don't know of anyone that does them anymore. So what we do now is we measure total testosterone, we measure the SHBG, and we can compute, because we know the binding the testosterone and SHBG, we can compute how much of that testosterone must be free. And so, that calculated free testosterone is available in all routine laboratories. But you can't get it unless you measure the SHBG, the testosterone. And it's the free testosterone which correlates with, clinical hypogonadism and so on. I think we might have talked about insulin resistance in the past, but the question is, what are the determinants of SHBG that might confound total testosterone interpretation? And one of the major determinants of SHBG is, insulin resistance as a general term. We're not really sure whether it's levels of insulin that decrease SHBG or whether it's fatty liver. SHBG is made by the liver. So a fatty liver might just be capable of producing SHBG. But if you've got low SHBG, your total testosterone looks low, but your free testosterone may well be normal. And this is a major confounder, because it's generally true that men with diabetes or prediabetes often have low testosterone levels, but they don't have low free testosterone. What they have is low total testosterone because their SHBG levels are low. And so it's really confusing. You've got a diabetic man that you do the testosterone, it's 8 or 9, which is slightly low. You measure the LH and it's perfectly normal. You think, there's nothing wrong with his testes. It must be something central. If you measured the free testosterone, it would have been normal in the first place. So I have to admit that, to me, doing testosterone without HBG is potentially misleading. Unnecessarily replacing testosterone has its own problems, which we might talk about. But so now some labs automatically add the SHBG. It's so important that you should. Labs think, well, we'll do it for you since you forgot to ask for it. Other labs are worried about Medicare coming down on them, and they sort of insist on doctors asking for it. Statistically, 60 to 70% of doctors who ask for testosterone ask for SHBG, because the reasonable practitioner understands that relationship. But unfortunately, some of them may not understand the importance of it. I do think that it's ideal would be laboratories always address HPG with testosterone.
Have you seen many people request gonadotropin-releasing hormone? Do you think that's useful at all?
I see people requesting it, but I don't think it's useful in the routine setting. Maybe for research or endocrinologists looking for very rare hypothalamic disorders. But, there are some hypothalamic disorders where the problem is at that part of the axis, children and so on. So, but it routinely, it's not available in routine labs. I would be surprised if there's only one lab in Australia that can do such a thing.
And is it useful to monitor patients with hypogonadism?
It's a loaded question. There's so many aspects. It depends on the type of hypogonadism they have. The thing that I'll say about hypogonadism is it can be normal. The stress, we think of, let's say, anorexia or sportsmen with hypogonadism, women who lose their periods and so on. That's a stress response by the pituitary. In stress, the pituitary will produce cortisol, growth hormone, all the stress hormones, and it'll switch off other hormones, including SH and LH and FSH. So in stress, it's quite common for LH and FSH to fall and lead to low testosterone levels. We probably realise that more than anywhere in the terrible phase of the early days of the HIV epidemic, when men got very, very sick, and their testosterone levels were low, and it was very confusing. It's just a stress response. We also see it in ICU patients. If you're curious enough to measure testosterone in an ICU patient, it'll be low. Not only that, but I did some work with some sports medicine doctors, and when athletes overtrain, that level of stress will drop the pituitary hormones and testosterone levels. So it's like a part of the overtraining syndrome. So if it's that sort of situation, think it's stress, well then, yes, treat them, get them to get away from the stress, and then monitor the testosterone recovery, which can take a lot of the pituitary axis things take weeks or months to recover. So if it's something that you can monitor and look for recovery. In other situations where, you're truly, got testicular insufficiency and you're giving testosterone replacement, well, there you're monitoring the testosterone as if it was a therapeutic drug and making sure that you're in the sort of safe zone of replacement. So definitely the answer is yes, you need to monitor. The reason why you monitor may be different depending on the circumstance.
What I take away from that is my heavy training 3 days a week in the gym and the stress that follows. Maybe I should be on a testosterone supplement, but I'll talk to Travis about that afterwards. Ken, do you have any final advice or thoughts on hypogonadism for doctors or patients?
It is a useful consideration, particularly in chronic fatigue. I think once you ruled out the common things, whatever it is, iron deficiency and cortisol, that's been much more worrying if you had cortisol insufficiency and Addison's or some thyroid dysfunction and so on. Once you've ruled out those common things, well then it is a second line of thought, and it is important not to miss. But I think the main thing is don't test for it properly. Get the free testosterone, get the LH so you can understand the complete picture. Do not treat somebody on the basis of a low testosterone alone. That is clinically unsafe, but I'm telling you, it's medico-legally.
On that note, Professor Ken Sikaris, thank you for joining us on This Medical Life.
Thanks.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.